Let me introduce then Emilie Aschenbrenner, who comes to us from the University College of Wisconsin. And I have to really thank her very much, as she's sort of a pinch hitter who very much at the last minute decided to come and enlighten us about practical issues in CAR T therapy. Thank you very much.
Thank you, Dr. Emmons, for the very thorough overview. I'm actually going to focus mostly on lymphoma treatment with bispecific antibodies. We are a center certainly that does offer CAR T-cell therapy and autologous transplant. And I can say you might hear a little bit of my Wisconsin accent, but most of my state is rural. We work with community sites all over the Midwest because we can't necessarily always offer therapies like CAR T-cell therapy. And I think about the health system we partner with even to the north of us. We kind of joke, but really about access to care for these patients. There's a bridge over a body of water called Butamore in French means hill of death. And really those patients sometimes see crossing the bridge to an academic center as a hill of death. So if we get them, we can offer these novel therapies. That's fantastic. Sometimes we can't. And as we talked about today with sequencing and myeloma and lymphoma, many of our patients will receive many of these novel immunotherapies with the bispecific somewhere along the way. So I'm kind of preaching to the choir with these slides, so I'll go quickly through them. We know that diffuse large B-cell lymphoma, over half our patients are diagnosed with advanced stage disease, and they certainly have room for improvement with 5-year survival. With stage 3 and 4 disease, just about 50% of patients that have 5-year survival. Now that the Scholar 1 data was presented now about 8 years ago, and just reminding ourselves, how did we get here as we're talking about immunotherapies today with relapse refractory large B-cell lymphoma. This is focusing on patients that had received salvage chemoimmunotherapy. That's what I learned how to treat patients with my lymphoma team when I first started as an acute care pharmacist with our platinum-based chemoimmunotherapy. And what this showed us from 2 observational cohorts and 2 large phase 3 clinical trials really is that we had a long way to go in terms of overall survival. This also included some patients that relapsed after autologous stem cell transplant less than a year. So pretty dismal overall with our patients only living about 6 months when we only had chemoimmunotherapy to offer them. Follicular lymphoma, we know, is our most common subtype of indolent lymphoma. Many of our patients are dying from other comorbidities, and this disease is characterized by slow progression. Our 5-year relative survival, even with advanced stage disease, is still very optimistic. But as we know, and as many of you have heard this term now for several years, our patients that have POD24 or that progress in the first 2 years of frontline chemoimmunotherapy, we know have inferior outcomes. And although there are characteristics which we can predict which patients will have these outcomes, there's really no uniform markers for implementation risk-adapted therapy when we start treating these patients. And overall survival is worse at both 3 years and 5 years for these patients that do progress. So even though it's an indolent disease, there's a need for novel immune therapies in these patients that progress. Again, highlighting what I'm focusing on today with lymphoid malignancies are bispecific T-cell engagers or bispecific antibodies that target CD20 and CD3, so bringing that malignant bringing the T-cell to that malignant B-cell. So Dr. Emmons introduced us to the key clinical trials for epcoritamab and glofitamab. So what I'm going to quickly do before we look at some practical applications and how we operationalize these therapies is just go through some of the recent data that was presented. We can't, for efficacy data and survival data, quite claim what we can for CAR T-cell therapy, where we can now really claim with lymphoma that we can essentially cure some of these patients, but the survival data is certainly maturing. So the EPCOR NHL1 trial, again, highlighting that this is in third-line setting, did include some patients with higher risk disease. And about a third of those patients had prior CAR T-cell therapy, although we know that those patients generally do a bit worse. With bispecifics after CAR T-cell therapy, we can see some response. So looking now at the 3-year follow-up presented at ASH this year, again, encouraging overall response rates, complete response over 40%. You can see the duration of responses presented for you there. And in those patients that they were able to test MRD negativity, just shy of half the patients were MRD negative. So I will highlight the adverse events. Certainly when we are sending patients back into the community setting, if we do step-up dosing at an academic center, we're really focusing on those cytopenias. We don't see the degree of prolonged or profound cytopenias that we see sometimes with our patients with CAR T-cell therapy. But we didn't see with the 3-year follow-up really new safety signals with these agents. The majority of our patients, we can manage the CRS, that's grade 1 and 2. Cases of ICANS and TLS are quite rare. Last summer, epcoritamab was approved for follicular lymphoma. So this is, again, in the 3rd-line setting. We don't have as long of long-term follow-up for these patients yet. So median follow-up just over 17 months. So this is in the 3rd-line setting for our patients that have progressed after 2 lines of therapy. Again, we don't use CAR T-cell therapy as commonly in this space because we have effective agents to give these patients, and it's a more indolent disease. But encouraging high overall response rates in this population of patients that had been treated with over 60% CRs. We can see our duration of response is not reached yet, including overall survival. I do want to highlight, and I'll have a subsequent slide, when we're using epcoritamab to treat indolent lymphoma or follicular lymphoma, we are adding a 3rd step-up dose. So I think of that when we're counseling patients and talking to our patients, we don't, in our healthcare teams, we really don't need to get to that target dose quite as fast. And what they saw with the optimization cohort for CRS, the 86 patients that they evaluated, was essentially no high-grade CRS. So we're able to step these patients up all in the outpatient setting primarily, and most of these are cases of CRS are grade 1. Because this was conducted during the peak of the pandemic, we did see quite a few cases of COVID-19, including some deaths from COVID-19. So moving on to glofitamab, we also have now over 3-year follow-up presented at ASH this year from the key glofitamab clinical trial in the 3rd-line setting for large B-cell lymphoma. Although it did include patients that had high-risk disease such as double, triple hit, that is not included in the labeling. We still sometimes can get insurance authorization for our patients that have that high-risk disease. Prior CAR T was allowed, and again, what we saw with epcoritamab, with glofitamab, high response rates, overall response rates over 50%, and complete responders about 40%. The data I presented for you there as far as duration of survival and overall survival was reported out from the trial from cycle 3 in patients with a CR. So keep that in mind. We're not comparing apples to apples. Similar adverse event profile to epcoritamab. What we do see with patients that are receiving glofitamab, sometimes a little bit higher grade cytopenias with these patients. And then moving on to our last agent in follicular lymphoma, mosunetuzumab, we actually now have over 4 years of follow-up for mosunetuzumab in the 3rd-line setting for our patients with this indolent disease. Again, they could have prior CAR T. That was only a handful of patients. Really encouraging overall response rates for patients. Survival data is presented for you there with overall survival in patients that had 2 prior lines of therapy at 83%. AE profile very similar. Again, this was conducted before the peak of the pandemic, so not so many cases of COVID-19 as what we saw in the EPCOR trials. So what I want to spend my last amount of time on for these agents, the recent updates to these agents, are how do we include them now in the 2nd-line setting in combination with chemotherapy in our patients where transplant or CAR T is really not on the table. They either had a prior transplant or CAR T, or they're not eligible for it. So this is the EPCOR NHL2 data, which is epcoritamab with GemOx. So this is phase 1/2 data we'll look at the glofitamab data, which is actually phase 3, but we have now over a year of follow-up from this patient population. These are patients who are ineligible or who have failed transplant. So they had to have at least one prior line of therapy. They could have prior CAR T-cell therapy. So we're combining epcoritamab with GemOx every 2 weeks for the first 4 cycles. What we can see in this patient population, encouraging overall response rates and CRs, the CRPFS and OS is provided for you there. And we ask ourselves, when we add these bispecifics to a chemotherapy backbone, what additional toxicity are patients enduring or encountering, and certainly see a similar profile with CRS and ICANS, but we can increase cytopenias when we add a bispecific. So NCCN does now recommend this combination for second-line therapy as an option for patients that have relapsed disease less than a year, or non-candidates for CAR T-cell therapy, or relapsed disease more than a year out and are not proceeding to an autologous stem cell transplant. So when we look at the STARGLO data, this is a phase 3 randomized, so we do have an active comparator now when we're comparing glofitamab GemOx with rituximab GemOx, so that is our comparator arm. Again, this is for patients that have relapsed refractory large B-cell lymphoma. They did exclude patients that had transformed disease that was indolent or high-grade disease. And if they had one prior line of therapy, they had to be ineligible or refuse an autologous stem cell transplant, although prior CAR T was allowed. The GemOx was given at a slightly increased interval, so a longer interval in this trial because glofitamab is dosed every 3 weeks. So not quite the same when, we're practically building out our treatment plans for patients. When we're adding it to the backbone, it's every 3 weeks for the first 8 cycles, and then patients go on to receive 4 more cycles of glofitamab. So follow-up in this trial is now about just shy of 21 months, 2-to-1 randomization. We can see about double the overall survival, including 24-month, and then the progression-free survival and CR are listed for you there that are statistically significant, favoring the glofit GemOx arm. So we ask ourselves again, what added toxicity when we're comparing our GemOx with glofit GemOx? Certainly our patients now are being exposed to some degree of CRS, although this is mostly low grade. And we can see slightly higher rates and grades of neutropenia and anemia. NCCN does give this the same recommendation as epcoritamab GemOx, but they do highlight its category 1 based on now that this is the phase 3 data for relapsed disease greater than a year after for patients not proceeding to an autologous stem cell transplant. So when we think about some pearls, practical applications for bispecific T-cell engagers in lymphoma, and when we're offering these therapies to our patients, we can think about route of administration. Epcoritamab is given subcutaneously, glofitamab and mosunetuzumab are intravenously. Generally, there's about 4-hour infusion, so we think about chair time, especially in our centers where space is limited many times, or we have overcapacity or high census, although those infusion rates can decrease with time. We also have to think about treating to progression for patients, as epcoritamab is a treat until progression. By the time patients are getting more than 10 cycles, and I'll have a nice visual for you, they're only getting 1 injection about once a month, but still that's 1 injection once a month, whereas glofitamab and mosunetuzumab are fixed duration. Fortunately, sites that have operationalized CAR T-cell therapy can do much of this step-up dosing, even for aggressive lymphomas outpatient. We are doing that as a default at Froedtert and MCW. Inpatient admissions still are recommended in the package insert for epcoritamab and glofitamab. So step-up dosing, just highlighting the difference for diffuse large B-cell lymphoma when we are providing these treatment options to our patients. We can see that it's more frequent visits for our patients with epcoritamab. Certainly more times they're at the treatment center, but it's a subcutaneous injection. And again, this is continuous therapy where glofitamab is intravenous. By the time the patients are getting to their target step-up dose, it's given every 3 weeks, and then it's a fixed duration of 12 cycles. Although there is some data that has presented for glofitamab retreats for patients that progress. Generally, we are offering them alternative therapies if they progress after that, having glofitamab treatment. When we compare agents for step-up dosing for follicular lymphoma, epcoritamab and mosunetuzumab, I do want to highlight that there's an additional step-up dose for our follicular lymphoma patients, so 0.16, 0.8 instead of getting to 48 on cycle 1, day 15, like large B-cell lymphoma. It's 3 milligrams to help mitigate some of those higher rates and grades of CRS. In fact, most of the patients in the trial had grade 1. And then mosunetuzumab is an every 3-week dosing. If patients achieve a CR after cycle 8, they're done. If they have partial response or stable disease after cycle 8, they can go on to receive 17 cycles. So fixed duration really depends on response after cycle 8. So I won't read all of this slide to you. You will have my slides available, but just this is a nice chart comparatively for when we have the peak incidence, median time to onset, duration, when we're step-up dosing of these 3 agents. I do want to highlight that the peak incidence of CRS is not always with the highest target dose. Sometimes that can happen, for example, with glofitamab, with the first step-up dose at 2.5. Grade 3 CRS is relatively uncommon, and then recurrent CRS rates are listed for you there. So I did add a patient case because pharmacists love patient cases, and when we're educating our staff, they like cases to apply. So it will have us contemplate how we would treat follicular lymphoma. I do have a second patient case I won't probably get to for sake of time today, but it's a good exercise if you want to bring that back to your teams about how to treat CRS with DLBCL. So many of our patients with follicular lymphoma, we can do our watch and wait approach because they don't all need treatment. Certainly this was a woman that was actually one of our patients that was diagnosed in 2017, incidentally on a routine mammogram with an enlarged axillary lymph node. She had surveillance for almost 5 years. We gave her standard R-CHOP, rituximab maintenance. There was some interruption of her maintenance dosing due to cytopenias. Unfortunately, recently progressed. We actually tried to get a bispecific, get an insurance authorization in the second-line setting and weren't able to receive authorization, so she started on an oral EZH2 inhibitor, tazemetostat. Really minimal response to that, and said, I've read about these aggressive therapies. I don't want that. I don't want CAR T-cell therapy and autologous transplant. So when we think about practical applications of our lymphoma bispecifics and how we would select them, again, discussing with her not just the safety and efficacy outcomes, but what kind do you want a shot, an IV infusion, potentially treat to progression or fixed duration. Certainly patient-specific factors for that. How far away does she live from the treatment center? What caregivers are involved? How much time does she have to stay there for an infusion if it's a longer infusion and we're giving her extra hydration, for example? And then what expectations do we need to set for patients and caregivers? So when we looked at her patient case, she actually received mosunetuzumab. We could have offered her epcoritamab as well. Generally what we see, this is pretty well tolerated for most of our patients. She did present to a local emergency department with grade 1 CRS and headache. With the low-grade fever, we just managed her with antipyretics and IV fluids. And then on her first full step-up dose, had some mild toxicity, including a rash and joint and muscle aches, which resolved with topical steroids. So many of you, or most of you, are aware that it's now been about a year since we've had consensus guidelines for CD3, CD20 bispecific antibodies and toxicity management. We've worked to develop our own internal guidelines, as many institutions have. It's kind of hard to say one size fits all when you have you're treating myeloma, you're treating lymphoma and solid tumors. We've tried to do a one size fits most with some caveats. So just highlighting, we can employ some protocols where we can really try to keep patients home with grade 1 CRS, especially if we're doing thorough education with the patient and the caregiver. So really at home, instructing them to have Tylenol and oral hydration. You know, we've kind of coined the term now pocket dex, while sending the patient home with dexamethasone, and to take that dexamethasone once they call in and talk to a provider, so we can try to avoid admissions. Certainly health system evaluation, whether that be an urgent care, if you have the resources for a 24-hour clinic. We have a small one with 4 beds. Generally, that's there's patients in those beds that have other toxicities like neutropenic fever, nausea, vomiting, and we can't always admit our bispecific patients there, but would need a health system evaluation with recurrent grade 1 and certainly grade 2 or higher, and the agents are provided for you there. This is an example of infectious prophylaxis. Many times we're sending patients back and forth to different health systems, so they don't necessarily have the same EMR. So really documenting or giving a warm handoff. It's important that our patients have antiviral and pneumocystis prophylaxis for these agents. And then we fold in bacterial, antibacterial, and fungal prophylaxis. This is just an example of a protocol if they have more prolonged neutropenia or at higher risk because they have toxicity where they receive corticosteroids, for example. So lastly, kind of just want to think about some logistical considerations when we're employing these agents, when we're giving these options to our patients with lymphoma. So what do we have to do when we operationalize this? We're not, it's kind of a hot topic, like financially ready to treat. Are we financially ready to treat as an institution? Is the patient been authorized and financially ready to treat at our facility? Certainly we have to ensure tocilizumab is available. We've worked with our community health systems and network in our community EDs within a 120-mile radius to have tocilizumab available to patients, even without a centralized pharmacy. Certainly educating personnel, not just the core treating team, but our ED physicians. Patient resources, minimally, they need to have a thermometer, a blood pressure cuff, and pulse ox are also ideal if possible. And then that supportive care. And patient and caregiver education, we kind of think about that as if this, then that. Sometimes we're using education cards that are almost like a stoplight, like red means stop and evaluate, yellow you can treat at home, green means go, you need to call, and certainly the contact information instructions after hours. Highlighting onboarding and operations of these agents, really leveraging our electronic health record has helped us with alerts. And then if the patient presents to an emergency department, they can link out to a guideline and order set and page the appropriate health team, both for our malignant heme and our solid tumor patient population. And then lastly, I'll just wrap up with this slide for sake of time. You know, education, we really encourage that our caregivers attend education with the patient so we can go through appropriate monitoring with the patient, vitals at home every 4 hours, twice daily neurologic assessment, and then direct care for at least 48 hours, especially after those step-up dosing, and being able to provide transportation for the patient at least 3 days or 72 hours after the step-up dosing. So these are just some conclusions. We know that we have improved response rates for our patients with follicular lymphoma and DLBCL who are not CAR-T or autologous stem cell transplants. Certainly successful implementation requires addressing logistical workflows, and multidisciplinary teams are essential for employing these agents and treating patients. So I'm happy to take questions, and if we run out of time, I'll be around during the break as well.
Are you using any prophylaxis with tocilizumab prior to outpatient bispecifics? Is it a criteria that you look into, or just
Yeah.
everyone who's getting outpatient would get tocilizumab?
So we have not employed that yet. You know, as you're aware, there's data in our patients receiving the BCMA bispecifics, our myeloma population. We've discussed it several times at our QI meetings, but we haven't routinely employed that yet. So we're risk stratified. Are you?
So we are.
Okay.
It's like there's an outpatient myeloma bispecific. We will use not 8 but 4
Oh,
milligram prophylactic dosing.
okay.
Actually, also do them for inpatient. They're at high risk of CRS. We give tocilizumab dose.
Okay.
An hour prior to the first dose.
Okay. Good to know.
What do you do for patients who go to a healthcare system that they want WCW, but they're at a regional site or a healthcare system that may not be able to do when they have access to this?
Yeah, so healthcare system, the question was, what do we do with patients that are not close to us or another healthcare system? Do they have access to tocilizumab? We can control, what we can control. We have a partner health system that we work to the north, and we have, Green Bay Oncology, go Packers, that they they generally stock. So our network we work to stock the tocilizumab in the unit dose med select with the mini bag, but we can't say every health system across the state of Wisconsin has to date. We do encourage it, especially if they're doing step up dosing, but really us and a few other systems are doing the step up to date.
Excellent talk.
Mm-hmm.
My question really is, I practice as a breast oncologist and genitourinary oncologist, and so in the community as well too. And I think that a lot of things that we're seeing, I think, within the community and reasons why Rob and I and others want to have meetings like this is to help educate those within the community, as a lot of those sites are really going for bispecifics on the solid tumor side, whereas traditionally a lot of the malignant hematology is handled by you guys for the most part in the academic centers as well too, and that's where CAR T and all other bispecifics are being administered as well too. So what's your advice? And I'm sure you saw, as MCW grew, what's your advice, I guess, for community programs out there like mine that are just sort of in the early infancy of giving bispecifics and things like that? I know it's a little bit of a loaded question there.
Yeah,
but
I think if I could take a step back with our team that's helped employ these, I think it's like get connected. We're usually sooner. We're usually more than willing to share our resources. Many healthcare systems are. So if somebody's developed a great patient handout or a way to leverage the EMR up front, we've treated now 30 talquetamab patients and learned from that. That's kind of a generic answer, but those resources are now available. There's some links at the end of this presentation too, but that's what I would say. Don't reinvent the wheel.
Definitely. And then
Yeah.
anything on the state level, I guess, in Wisconsin that you know of, I guess, in terms of education for bispecifics or things like that?
I think a lot's coming through national organizations, not necessarily our state level,
Okay.
but pharmacy, APP, physician organizations, large organizations. So.
Excellent. Thank you.
Mm-hmm.
Yep, that's exactly what I was thinking. So.
Thank you.